Welcome to the MS-Perspektive podcast, Perspective with a K as I'm German. I'm Nele von Horsten, MS patient, patient advocate and author. I'm bringing you interviews, inspiration and information about living with multiple sclerosis and show you ways how you can positively influence the disease and make the best out of your diagnosis. On ms-perspective.com you will find the show notes, 11 free tips as a PDF and lots of other information. And now the show begins. Thanks for tuning in again and welcome to episode number 143, How Menopause Impacts MS. Hormones, biomarkers and what women need to know with Dr. Riley Bove. And now enjoy the interview. Hello Riley, it's such a pleasure to have you on the show and thanks for taking your time and hi to California.
It's a pleasure to be here. Thank you so much for the invitation.
And before we actually start with the interview, it would be lovely if you could introduce yourself to the audience so they know who is with me on the podcast today. And if you could tell us a little bit about your background and research focus, that would be great.
So my name is Riley Bove. I'm an associate professor of neurology at the University of California in San Francisco. And I've been here for about 10 years. I'm trained as an MS neurologist. But before that, I was also trained in anthropology, understanding specifically women's health within the broader social cultural, medical anthropology, and even evolutionary context. I've always been quite interested in women's health and understanding changing behaviors, changing perspectives, around sex and gender, changing cultures can really influence women's health. And I think moving to multiple sclerosis, we really see a lot of ways in which culture and medicine and such can affect women's health in MS specifically.
Great, fantastic. And what led you to study the intersection of menopause and multiple sclerosis?
Yeah, so thinking about menopause, there was this really landmark book written by there was a landmark book written by a medical anthropologist. Her name is Margaret Locke, and she studied menopause in North America and Japan. And she noticed that women's cultural, emotional, familial, individual experiences of menopause were different across different cultures, and also even their biological symptoms. So even the hot flashes, the other symptoms that you associate with menopause were different in different cultures. And so I've always been really interested in that phenomenon. And when we think about menopause in the life of a woman with MS, most women, about 90% of women, are diagnosed before menopause. And so most women with MS are entering menopause already with their multiple sclerosis. Some will be diagnosed around the time of menopause, and then a few will be diagnosed after menopause. And so for women with MS, there's really a lot of questions about what is the perimenopause, what is the menopausal transition going to be like, living with both MS and menopause, and also how will their MS change after menopause and a postmenopausal lifespan. So both perimenopause and postmenopause are really important for women with MS.
Okay, interesting. I never heard about these differences in cultural, differences in symptoms in the different cultures. Very interesting. So what hormonal changes occur during the menopausal transition, especially in the perimenopause, in our cultural background?
Yeah, so the typical transition, of course, is as the antral follicle count, so the number of follicles that remains in the ovary decreases, we see a lot of hormonal changes. So we see progesterone kind of starts decreasing first, and then we see a lot of variation in estrogen levels in the last years of the reproductive phase, and into the perimenopausal phase. You see estrogen levels, sometimes they can be very high, sometimes very low. There can be a lot of fluctuations. After the antral follicles are sort of expended, there's none left, then estrogen production can decrease. And of course, we don't measure estrogen and progesterone really to sort of decide if the woman is in perimenopause or postmenopausal. We understand that those levels are going to fluctuate a lot. What we look for is the FSH, follicle stimulating hormone. That hormone is produced by the brain in response to those decreasing levels of estrogen. And the FSH, sort of the brain kicks that FSH production into high gear, trying, maybe to tell the ovaries, come on, let's keep up. And so the FSH levels start to rise during perimenopause, and then they're elevated postmenopausally. And so that's the hormonal signal. And then, of course, in women who have a uterus who do menstruate, we also look for the absence of menses. So the hormonal changes can take many years, actually, and they can be very different from woman to woman. But overall, we see declining production of estrogen, declining production of progesterone, and then the FSH levels rise.
Okay. You already gave some, let's say, boundaries. So are all women affected the same way by menopause, or are there significant individual differences?
There are significant individual differences. So first of all, we know that many lifespan experiences, things that happen earlier in life, can affect even the timing of menopause or the quality of menopausal transition. So, for instance, smoking or other earlier life exposures can affect when someone has their final menstrual period. During that perimenopause, as the hormones are shifting, we typically think of the vasomotor symptoms, so hot flashes, night sweats, cold sweats, things like that, as the most typical symptomatology. And some women can cruise through the menopausal transition with very few hot flashes, few vasomotor symptoms, while other women are really profoundly affected. Hot flashes all day and night, interrupting sleep, waking up sweating, with significant sleep disruption then affecting daily wellness. We also see many other symptoms, and again, back to women with MS, we see, in addition to the sleep disruption, we see fatigue, some mood changes, so depression, anxiety, irritability. We see some increasing joint pain, frozen shoulder, sort of stiffness in the joints, things like that. We see some changes in bladder and bowel function and decreasing libido. And all of those things, of course, are very familiar to women with MS, right? So these symptoms are very common across the lifespan in individuals with MS. And so those are what we call sort of the overlap symptoms of perimenopause and MS. In that experience, my patients often say these three very characteristic things. They say, I don't know if it's my MS or my menopause or both. And I think what they're really saying is, who's going to help me manage this, right? And they also wonder, they worry that it's from their MS and that means that their MS is progressing. So that's another big thing I hear. And then I also hear, this other overlap symptom that we really don't have a great handle on and need to have a better handle on, and that is the cognitive changes. So during perimenopause, in the general population, it's very common for people to have some perhaps mild cognitive changes in the sense that if you test them, they're cognitively not impaired, but they definitely notice a change with respect to their own baseline. And that can be in word finding, that can be in executive function, it can be in attention. So often when they say, oh, I never knew I had ADHD until now. And then also some difficulty with working memory. So there can be these differences in cognition that may be subtle to others, even if they're very you know, present to the person who's experiencing them. And again, those cognitive symptoms are very similar to the cognitive symptoms that people with MS have. So many of the patients with MS, are worried that their cognition is really off and that they're now having significant cognitive impairment.
Yeah. How well informed do you think most doctors, including neurologists and gynecologists, are about the impact of menopause on health?
Mm-hmm. It's a great question. I think it depends. So up until the last 3-4 years, I think we were really living with very, very little information on this topic. Cognitive studies were not doing a great job of capturing the changes. Neurologists never actually really were trained in understanding the neurological sequelae of menopause. So they really thought of it as a women's issue, a women's quality of life issue, a gynecological issue, and not so much a brain health issue. And so, I give a lot of lectures and grand rounds and sort of conferences and such. And I like to ask people in the audience of all the neurologists, who has ever had 1 hour of training on menopause and brain health? And the number is very, very small who raise their hand. Thankfully, we're seeing an explosion of interest right now. A lot of people hopping into this field, a lot of people trying to do catch-up training to understand what are the options, what are the different, interventions. We're looking at long-term epidemiology studies. We're looking at menopause and the traces on the female brain. So we're really sort of in a sort of newly invigorated time, thankfully. But most neurologists are not well equipped at all to understand what's happening. They're not well equipped at all to understand the differences between perimenopause, those years surrounding the final menstrual period, and postmenopause, the years after the final menstrual period. And I don't think there's really been a women-centric perspective on this.
Yeah, that's a
Mm-hmm.
big issue behind that.
Mm-hmm.
Talking about options, could you explain what bioidentical hormones are and how they differ from traditional hormone therapy?
Yeah, so that's a great question. In my mind, I think we certainly don't have a lot of training or even, let's say, standardization in how we think about bioidentical hormones. And so the idea would be that you're using, sort of substances that sort of are, have the same chemical property as those that the body produces, and that maybe, come from more natural sources, so sort of plant origins, things like that. I think there's a lot of heterogeneity in formulations and the testing, and so compared to sort of the sort of more synthetic products that you use, and so I think a lot of women like the bioidentical route because they feel like it might be more, again, naturalistic. But I find it difficult because there's less sort of standardization and sort of understanding expectation and effect.
Okay. What are the benefits and risk of hormone therapy for women with MS during or after menopause?
So I love your question because you're really distinguishing what might be a benefit during perimenopause and menopausal transition, and then what we know about long-term effects. So if you think about the menopausal transition, uh, the Menopause Society, amongst others, have really said that systemic menopausal hormone therapy is the most effective treatment for vasomotor symptoms. And so what we talk about when we're talking about systemic is an estrogen. And then you pair it with a progestogen if the woman has a uterus. So you want to protect the uterus from sort of excessive stimulation by the estrogen. So if we think about systemic estrogen, plus minus either progestogen or a selective estrogen receptor modulator or some other sort of uterine sort of protectant. That systemic estrogen, it is very effective against menopausal hot flashes based on those symptoms. It also has benefits for bone density. It has benefits for sort of urogynecological symptoms, quality of life. Some women talk about benefits for sleep, etc. So during the menopausal transition, there can be a lot of symptom alleviation from the systemic menopausal hormone therapy. I'll just distinguish that systemic from local, so you can actually get intravaginal estrogen, which is just really for your gynecological symptoms, vaginal atrophy, vaginal sinus, bladder symptoms, etc. Now, if we think about what are the benefits long term and risks long term of that systemic menopausal hormone therapy, of course, we've kind of reshuffled our understanding and our appreciation of this recently. And it's important to talk about the Women's Health Initiative, which is this landmark study. And the Women's Health Initiative was a landmark study that read out in the early 2000s. During the study, they gave systemic menopausal hormone therapy to women in their 50s, but also women in their 60s. And what they saw for the women in their 60s is that there are actually a number of risks. And so they decided that the menopausal hormone therapy was basically bad for everybody. Now, if you go back and look carefully at the women who got menopausal hormone therapy just within what we call the window of opportunity, within 5 years of their final menstrual period, of their age at menopause, you actually see some benefits long term. So you actually see decreased risk of all-cause cancer, decreased risk of heart disease, decreased risk of all-cause mortality. You also have, improved bone density. So it's important when we're thinking about, the kind of time, span, what risks and benefits are we thinking about? You do see a slightly elevated risk of clotting and stroke. And so we think that the transdermal estrogen is better than the oral estrogen for that. And so then the question is, besides those risks and benefits, what about women with MS, right? So in women with MS, overall, we think of the risks and benefits very similar to the general population, with the following sort of caveats. If they're very immobile, then we might worry more about the risk of clotting. And so we might consider, again, the transdermal formulation. If they are experiencing significant hot flashes, we think, well, we know that heat precipitates symptomatic exacerbations in multiple sclerosis. That's a well-known phenomenon. It's called heat house phenomenon, right? So we really might think that we really want to tamper down on the hot flashes because we know they can then trigger all kinds of symptomatic worsening for patients, not just the hot flashes, but tingling and insomnia and such. And so I think those are the two main sort of extra considerations. The third one is estrogen neuroprotective? Do we have really convincing data that use of estrogens long-term protects against cognitive decline, protects against dementia? We see it in observational studies. We don't see it yet in clinical trials and interventional studies. And so I think that's the big sort of question mark. We haven't had interventional trials that have followed women for long enough in a sustained way to really ask that question properly yet, of whether giving estrogens around the time of the final menstrual period protects brain health. We see it protects against cardiovascular outcomes. We see it improves quality of life. We see people feel better for a variety of reasons. And you could hypothesize that that's going to protect brain health as well for all those different pathways, but we haven't seen it yet.
Okay. But because the question was not asked properly yet, right?
Yeah, we need more time and more trials to ask that because we see it clearly in the observational studies
Yeah.
and the epidemiology, but you need the interventional trials to really understand the effects.
Great. Yeah. Okay. Got you. Um, m- is there maybe a point when it might be too late to start with hormone therapy?
Yeah, great question. So we really think that, sort of this window of opportunity, you would start the menopausal hormone therapy within the 5 years after the final menstrual period or before. Beyond that, the hypothesis is the estrogen receptors really haven't seen estrogen for years, right? After the final menstrual period. And maybe then when you sort of flood them with estrogen, there are, more adverse, risk for downstream effects. And so the idea is really that the window is within 5 years.
Okay. And do women feel the right point when they use a hormonal IUD?
Great question. So a hormonal IUD is typically a progestogen. So typically that would not be, with the estrogen that would be sort of giving the putative beneficial effects. And so women who have a hormonal IUD, typically that's just really for their endometrial lining, and it's not so much for systemic effects.
Okay, but it's because I think then sometimes you don't really have a period, but you would still realize when your
Oh,
final
yes.
period is done?
Yes, that's a great question. So, women who use hormonal IUDs, as you say, sometimes don't get their period. And so you can't determine what stage of reproductive aging they're in based on their period because they're not getting it, as you said. So for those women, if they still have their ovaries, you would expect them to still go through all of the stages of reproductive aging without having their periods to gauge where they are. And so for those women, it's similar to women who've had a hysterectomy, for instance, who also don't have a uterus for menses. And so you would gauge based on their symptoms and based on their FSH levels
Okay,
what phase they're in.
okay.
Yeah.
Um, yeah. What changes did you observe in functional outcomes and biomarkers such as neurofilament light chains in your recent
Mhm.
study?
Yeah. So, in addition to sort of this perimenopause, where we've really been sort of focusing on what are the unmet clinical needs, what are the questions, how do we get people to start counseling women by age 45? How do we, really comprehensively address wellness and brain aging? We've also been asking what is the impact of that loss of ovarian estrogens on longer term functional outcomes in multiple sclerosis. And we initially asked this looking at the disability outcome, the EDSS, Expanded Disability Status Scale, which is a very coarse, insensitive outcome. And different groups have found different findings. It depends partially how well people are doing as they enter menopause in different cohorts. It depends also on how long you've followed them before and after. And it just, is not a good measure. So what we did is we looked instead at these more granular quantitative functional outcomes. So we looked at neurofilament light chain, which is a blood biomarker of disability progression. And we looked at the MS functional composite score, which is a functional outcome. It encompasses, as you know, a cognitive measure, a dexterity measure, and a gait measure. And we looked at those two outcomes and we found that for each, we see that the slope of worsening after menopause is a little bit more steep than before menopause. It's not a absolutely dramatic change, no. But we see that menopause does represent an inflection point where we might expect sort of the biological aging, reproductive aging, chronological aging kind of effects to result in some acceleration in the slope of brain aging.
Okay.
Mhm.
So what advice would you give to women with MFs who are approaching or going through menopause in terms of managing symptoms and staying proactive?
Mhm. I think a big uh, question that we don't really have a good handle on is if we do everything right during perimenopause, is that going to then keep people healthy postmenopausally? We don't have the data, but we certainly have the hypothesis, and it certainly is important that we try. So I would tell women starting at age 45, hey, you might not reach your final menstrual period for 2 years, 5 years, 10 years. Okay. Median age at natural menopause in women with MS is same as the general population, 51. So half have reached menopause by 51, half is no, half have not. So, we say, you may not have this anytime soon, but I want you to be prepared for if these symptoms, you thought you were very stable for many years, you've been on your MS therapy, you've been on your symptomatic therapy, doing well. If you start feeling the symptoms worsen, do not panic. It could be perimenopause, and we have a lot of interventions. So certainly, if the hot flashes are bothersome, they should be treated. It can be with menopausal hormone therapy. It can also be with medications that are other, right? So fivolinetant is a new medication approved in the US 2 years ago that just targets hot flashes. It's not hormonal. We also have a number of other medications, the antidepressants, gabapentin, that have some effect on hot flashes. And then there are lifestyle changes. So hormone therapy may or may not be the right approach, but if it's not, try something else. Okay. So don't suffer is the bottom line. There are many options for you other than suffering. Um, and then, really thinking comprehensively, so seeing the neurologist and the primary care doctor perhaps more often for a few years to get a handle on irritability, depression, sleep, bladder, joint pain, etc., to really have this very comprehensive approach. And then thinking about longer term heart health, thyroid health, cancer screening, gynecologic screening, all these kinds of things. Really using perimenopause as a kind of midlife checkpoint to encourage healthy aging. So I think really focusing on all the things we can do, all the rehabilitation, symptomatic, modifying interventions that you have in your toolkit to help women feel better. And then thinking about postmenopause, I think, we know that hypertension, heart disease, we know that comorbidities, um, we know that social isolation and depression, um, all these things, we know that they can worsen MS-related progression. And so just again, making sure that we're as comprehensive as we can be about all of these, factors to prevent progression as much as we can.
Great. And you were just mentioning the lifestyle strategies. So, what kind of lifestyle strategies might help complement hormone related approaches or not using them?
Yeah. So for vasomotor symptoms, there are some studies that suggest that have looked at acupuncture. Some studies have looked at even hypnosis. Some have looked at nerve blocks. These kinds of things, um, I think, can be informative. Some studies have looked at weight loss. And in the United States right now, there's a big trend for women to get GLP-1 agonists as well as hormonal therapy during perimenopause, which is sort of an evolving trend that we'll have to understand how it plays out. Um, we certainly thinking about having, really well-regulated sleep. So in this pharmacology is required for sleep. and if evaluation of sleep apnea is required. These are really important strategies as well, because people feel more resilient when they have a good night's sleep. And then, sort of the other things that we typically say, dressing in layers, doing the hardest, physical activity or mental activity early in the day, these kinds of strategies that can help some people.
Okay.
Yeah.
Riley, what do you think? What are the biggest research gaps right now when it comes to menopause and MS?
I think we actually know a lot about perimenopause. So I think as every neurologist who's treated, 100 women with MS, has been listening, we hear the same thing from many of our patients. And, others and I have created a number of sort of care guidelines to just kind of try to help people um, fill in a lot of the gaps there. Um, I think the things that we really don't understand well are sort of cognition and then uh, looking at long-term effects. So if you take a step back, so away from multiple sclerosis and look at the general population, you see that women who have earlier age at menopause and abrupt menopause as a result of surgical interventions, for instance, bilateral oophorectomy, those women actually have an elevated risk of cognitive decline, of Alzheimer's disease, of Parkinson's disease, MCI, etc. So we do see that midlife timing and type of menopause leaves a trace on the brain long term. We haven't really followed women with MS for long enough in large numbers enough to understand really sort of those outcomes long term. As I mentioned, we've looked at EDSS a little bit, we've looked at these functional outcomes a little bit, but really understanding what might be the long term signature and what are the mechanisms that we can target to promote brain health. I think so. That's the big scientific gap, and we're just scratching the surface right now. We're, tip of the iceberg. I think there's going to be a big explosion in this area as well, to really understand what are the potentially modifiable pathways by which menopause may influence brain health in women.
Okay, and talking about that ice mountain, which developments in this area would you most like to see in the next 5 years?
I'd like to have us really build up our cohorts that are robust enough to really understand how cognition changes, how biomarkers change. Um, and I'd like to see, tackling perhaps the women who've had surgical menopause because they're more sort of it's almost more experimental in a way. Sort of there's a clear pre-post if someone has had surgical menopause. So I'd like to see us really drill down on these questions. Um, and I think that will be very informative. If we have well phenotyped cohorts, we have good biomarkers, we have a subset of women with surgical menopause, we'll be able to ask and answer a lot of questions of relevance.
Okay. So, what message would you like to share with our listeners, patients, caregivers, clinicians, and researchers?
Oh, thank you. I think really we want to be, first of all, validating the patient experience. I think because so many patients see such similar things, and of course everybody's different, but because so many patients are saying such similar things, I think we really need to hear them and we really need to address their questions and gaps, which really are about progression, about cognition, about comprehensive care. Um, so I'd like to see, clinicians and care teams think really collaboratively and comprehensively, um, and to support messaging that prevention, symptomatic care, comprehensive care is key to wellness during perimenopause, and may also be really relevant to maintaining brain health post-menopause.
Fantastic. Riley, where can people follow your research or get in touch if they want to learn more?
Well, they're welcome to email me at my email address, riley.bove@ucsf.edu. We do have a lab site as well, bovelab@ucsf.edu, and happy to speak more with anybody interested.
Fantastic. Thank you very much for all that insight, and good luck with all the research in the future. And yeah, thanks a lot.
Thank you for profiling this very important topic for our patients. Thank you.
Thanks. Bye-bye.
Bye.
I hope you enjoyed the interview, learned something new, and yeah, maybe even got inspired to talk to your neurologist, your gynecologist, or become more active if you are in that interesting phase of perimenopause. For me, this really was a topic where I was, looking for a long time to get an expert like Riley Bove, and it's really great she had time and was giving us some guidance. By the way, next time I will talk to Kristen, and we will talk about her accessible adventures, how Kristen turned a wheelchair journey into empowerment. So stay excited and don't miss out on that interview. It will be an interesting one. And yeah, meanwhile, please stay as healthy and positive as possible and recommend the podcast to whomever might be interested in it. And please rate it wherever you are listening to it. And with that, see you next time. Bye. Thank you for listening today. I hope you found it helpful. You may also be interested in the previously published episodes and posts, which you can find at ms-perspektive.com/podcast. Perspective with a K. You can also get a free PDF with 11 tips for your positive impact on MS at ms-perspektive.com/newsletter. If you'd like to get in touch, you can reach me at nele@ms-perspektive.com or on social media. See you next time.